Uh, Good evening, everyone. Welcome to the masterclass session, which we bring across every alternate Tuesday. And we had a recent break where we had done recent updates on different topics, like sepsis updates, and we have done critical care, growth in the current generation. Now we are back to the masterclass. And today, to present this class, we have Dr. Rahul and Dr. Awais, who are from Yashoda Hospitals, High Tech City, who will be presenting this case. And to moderate this session, we have Dr. Ashish Hegde sir from PD Hinduja Hospital, past president ISCCM, and we have Dr. Parshottam Lal Gautam sir, senior consultant and HOD from Ludhiana. Thank you for joining, sir. We'll move over to the students for presentation.
Good evening, sir.
Good evening, sir.
I'm Dr. Rahul.
I'm Dr. Awais.
So we'll be presenting a case on organophosphorus poisoning. So to begin with, we had a 50-year-old male patient who presented to emergency department on 20th April of 2026 with alleged history of consumption of unknown quantity of dimethoate compound. Time since ingestion to the ER arrival at our hospital was approximately 12 to 14 hours.
We'll start with that only. How do you classify organophosphorus?
Sir,
Different types of classification.
Sir, organophosphorus poisoning can be classified on based on chemical classification, that is dimethyl and diethyl group.
Okay.
In dimethyl group,
No, that we'll talk about. I'm just talking about the classification. So one is dimethyl or diethyl. What else?
Dimethyl diethyl group on based on phosphorus, if it is phosphorus or phosphorothioate group, if it is
No, I'm saying organophosphorus. No, there's no chloride. It's organophosphates. So
based on the prodrug, sir, it is based on thions or oxons.
The thions or oxons.
And WHO classification, based on the severity.
First, the WHO classification.
Based on the severity. Based on the severity, sir.
So WHO classification, dimethyl, diethyl, phosphones and oxones. What else?
Thions and oxons.
And based on lipid solubility, sir, if it is high lipid soluble, intermediate lipid soluble, and low lipid soluble.
The applications we'll talk about later, but yeah, so these are all the different classifications that you have.
Yes, sir.
Fine. What are the implications we'll talk about later. Fine.
Okay, sir. So coming to history of presenting illness, with alleged history of consumption of unknown quantity of dimethoate 30% near agriculture field at village in Maharashtra, he was found in a drowsy state at around 4:20 p.m. by his family members. Initially, he was taken to a local hospital within an hour and shifted here for further management. At presentation at outside hospital, he presented with multiple episodes of vomiting, around 7 to 8 episodes, which was pungent in smell and associated with diarrhea. The presenting vitals at outside hospitals were he was initially drowsy but arousable, he was following simple commands, and he was able to talk. His heart rate being 55 beats per minute and blood pressure was on a lower side, 100 by 60 mmHg, saturation of 90% on room air with respiratory rate of 25 per minute, and he was afebrile. Pupils were pinpoint.
What are other causes of pinpoint pupils?
So we see it in opioid poisoning, we see in pontine hemorrhage or pontine bleed.
How do you separate opioid from organophosphorus?
In organophosphorus, there will be slut symptoms, sir. In opioid, the gastric symptoms, there will be paralytic ileus and urinary retention.
One vital sign separates organophosphorus from opioids.
So there is more secretions, salivations which are noted in.
Vital sign.
So respiratory depression will be seen in opioids.
What do you mean by respiratory depression?
Respiratory rate will be, bradypnea will be there, sir.
Bradypnea, why not will be tachypnea?
Bradypnea.
So the rate will be decreased in the other. Of course, there are lots of other signs. I'm not denying that.
Sir, coming to systemic examination, apart from drowsiness and arousable, they were on respiratory auscultation, bilateral creps were heard, and abdomen was normal in examination. Abdomen and musculoskeletal, there were no significant abnormalities were found.
So what are all these symptoms and signs of poisoning?
So, sir, in this case, we see that there is a bradycardia.
Not in this case, in general.
So sir, do you mean the signs and symptoms in?
Organophosphorus, this classic, because for the sake of this
Yes.
patient, we know he has all these things, but just for routine.
Sir, we see muscarinic symptoms and nicotinic symptoms. For muscarinic symptoms, we see salivation, lacrimation, urination.
Yes, like
Uh,
symptoms. Okay, what else?
The symptoms, along with we see bradycardia, bronchoria, bronchospasm. And for nicotinic symptoms, we see.
Can you have tachycardia with organophosphorus poisoning?
Yes, sir. Tachycardia and hypertension can also be seen due to these are features of nicotinic receptors, where tachycardia, hypertension is seen, along with fasciculation, tremors can also be seen.
Can you explain the reason for the tachycardia? What are the reasons which leads to hypertension, tachycardia? It's only pure. See, all based on the nicotinic or this thing, it depends on where it's firing. So if you say the nicotinic, what are the receptors where the nicotinic leads to hypertension and tachycardia? Because this is odd symptom in 10% of cases where the patient will not be present with a classical toxidrome. So there is, can you explain the mechanism of tachycardia and hypertension? What leads to tachycardia? What are the transmitter which leads to tachycardia? How it leads to mechanism?
You said nicotinic, no? Nicotinic where?
Yes.
Sympathetic.
So where the sympathetic stimulation comes? You are right that it leads to sympathetic stimulation.
Sir,
What are the organs or glands which produce tachycardia and hypertension in OPs pointing through the nicotinic receptors? Like we have the muscarinic, we have the heart, we have the muscarinic, we have the eye, we have skin.
Glands.
There are some pre-ganglion post-ganglion fibers where these are released. And there are specific sites where the post-ganglion fibers are based on the acetylcholine.
Ultimately, where all is acetylcholine released? That's the main issue now.
That's the main issue, yes. Just think of, you will get the rationale. What is the supply of the adrenal medulla?
yes, sir. Adrenal medulla, well, catecholamines will be there.
Catecholamine is released through the acetylcholine only.
Yes.
And similarly, why the sweat happens is it's through a sympathetic system, but it leads to this thing because it releases again through the acetylcholine only.
Okay,
That's
sir.
very important to understand wheresoever the acetylcholine is working.
Okay, sir.
Okay, go ahead.
Yes.
You also CNS symptoms. You didn't talk about CNS, so you have nicotinic, muscarinic, and
Nicotinic
CNS
symptoms.
also. You can have nicotinic can be in the peripheral muscles. Nicotinic can be in
With
the
the CNS. Sir.
CNS.
Sir, at outside hospital, gastric lavage was done.
So, what are your views on gastric lavage for organophosphorus poisoning?
Sir, if patients arrives immediately around within a 1 hour, I think gastric lavage will be useful for these cases. But overall evidence show that gastric lavage there is not much evidence in.
Why not beyond 1 hour, you think?
Sir, sir, we believe that poison can be still present in the gastric content, which can be removed.
So why not beyond 1 hour?
Sir, because it is a very this cholinergic organophosphate poisoning causes increased motility, so there is very fast emptying in these compounds.
So which poisons you can do beyond 1 or 2 hours?
Sir,
In the compounds which has a delayed gastric emptying, such as opioids,
tricyclic antidepressants or slow releasing tablets,
What is tricyclic? Which other drug similar to tricyclic?
benzodiazepines,
Benzodiazepine, similar to tricyclic.
antipsychotics.
Cholinergic effect is there. Which common
What are
poison?
the precautions? Oh, yes, just go ahead, Dr. Again. What are the precautions while thinking of gastric lavage? Because OPC poisoning is the resuscitation and the emergency care is much more important than the rest of the things.
Sir,
So you said the gastric lavage, what will be the preference, priority wise? The patient has come to you and there is nothing like a history specific, like you said the patient had a alleged history. If the patient comes to the casualty, but there is a hidden history of OPC, and patient is having bradycardia, bronchoria, and patient dying of desaturation. So how will be your approach so that you can rescue? What are your priorities stepwise? How will you get the oxidation, ventilation, and these things done? Or you are thinking of gastric lavage, that is also preventive measure. So how will you handle on the priority basis so that we can avoid iatrogenic mishap?
My primary intention will be of airway. I'll make sure that airway is patent and airway is secured if the patient can maintain his airway. If there is any doubt,
So these patients are mostly restless. They have a lot of secretion in the oral cavity and around the face, lacrimation and bronchoria. They are dying of secretions. And patients are restless and they don't allow you handle the airway easily. So how will you proceed with the? We have a. You will start. What will be your choices of drugs handling these and?
I'll start off quickly with atropine injection. I'll start with a 2 milligram dose and will be repeating every 5 minutes. So that I can control the crisis of cholinergic crisis, because I can see there's a threatened airway because of salivation, bronchoria.
Some people say atropine first or oxygen first.
Oxygen first, sir.
Sir, I'll go with atropine.
Both are your confused. So, or both things are together.
If
So
possible,
desaturation is killer, bradycardia is killer. Secretion of drying of secretion is possible only with the atropine.
sir, if possible, both together would be the best option. And and I'll be ready for securing an airway. If
Okay. So,
yes.
but if patient is not allowing you to handle the airway, what will you do? Can we do something drug assisted?
I'll use benzodiazepine, sir.
So we can use benzodiazepines to calm him down, and at the same time,
Most of these patients are so much hypovolemic. If you give any drugs, it will be difficult also. And a relaxant to facilitate ventilation
sir, in this case,
or not required.
Not required, sir. When we have an antidote, so we'll try an antidote first, sir.
No, but if you want to intubate the patient, he's hypoxic, bronchoria, not protecting his airway.
And restless.
Initially, we'll give an antidote trial, sir. If he's improving, then we'll continue with antidote. If it's not improving, then we'll think of other things.
So, what is the cause of death in OPC poisoning in the emergency?
so threatened airway because of aspiration and respiratory compromise.
It's a respiratory failure, basically,
Yes, sir.
which is because of hypoxia and patient dying of too much secretion, bronchoria, which kills the patient because of poor this thing. And along with it, complemented with the compounded with the bradycardia and hemodynamic instability.
Yes,
So
sir.
picking up the drugs is very important. We have 2-3 drugs which can be used safely. Benzodiazepine as sedative is not a good choice in these patients unless until the patient is having seizures, because it leads to hypotension and other things. Yes, oxygenation and muscle relaxant. If you have to use, which one is a preferred one?
So we'll go
Non-depolarizing muscle relaxant will prefer, sir.
with rocuronium.
Short acting.
Will prefer.
Why not scoline? Why not scoline?
Sir, in organophosphorus poisoning, it already hampers the concentration of butyrylcholine esterase. So scoline is metabolized by butyryl.
Go ahead.
Okay, go ahead.
No, other drugs he talked about. No? What are the drugs?
Sir, at outside hospital, atropinization
No,
was
for intubation. He talked about drugs for drug-assisted intubation. So he said he'll avoid benzodiazepines, he will avoid scoline. What drugs can you use to assist your intubation? That's what Dr. Gautam was asking you.
So for induction agent, I can go with ethomidate along with fentanyl, sir, and followed by use of muscle relaxant, a non-depolarizing muscle relaxant.
What about ketamine? Can we use it?
So ketamine causes secretions, and we are already dealing with secretions, so I'll better avoid it.
What about propofol?
Propofol can cause further sympathetic blockade and further hypotension and bradycardia.
Hypovolemic patient, propofol can lead to further compromising the hemodynamics.
Yes.
Not good choice.
Yes. So I think fentanyl and ethomidate will be the better options for this case.
Fentanyl, even ketamine, sometimes if you can supplement with along with atropine immediately, because atropine is going to be given to these patients on priority only. Sometimes people have debated atropine versus oxygen first. But ultimately, people thought that by hook and crook, oxygenation is takes over. But atropine is equally important, because unless until we give atropine, patient is not going to get improved, because this is the only way we can handle secretions and bradycardia.
Yes, sir.
So atropination was done. So what is called atropination? How you will reach the atropination? What is the maximum dose? How will you go ahead with the protocol?
There is no limit for atropine, sir. We can give maximum of.
Okay, so what is the dose he's saying? How do you decide? Give enough.
We'll initiate with 2 milligrams of atropine, sir. For every 5 minutes, we will assess the signs of atropinization. If there is no atropinization achieved, we'll double the dose for every 5 minutes until the atropinization is achieved, sir.
So what are your endpoints?
My main endpoint will be the clearation of secretions by achieving adequate oxygenation.
Oxygenation? Oxygenation you'll get with giving oxygen. Is that your endpoint? Oxygenation or
Clear lungs, sir.
yeah, clear lungs and auscultation. Oxygenation, you give enough oxygen, you can maintain oxygenation. So one is clear lung and auscultation. What else?
Heart rate of more than 100 on the first day and blood pressure, systolic BP of more than 90 mmHg, sir.
That's it.
Additionally, we can look for gastric pupils and bowels, sir.
So heart rate is 100. Breath sounds are clear. BP is 90, but pupils are still pinpoint. What will you do?
Sir, if even though pupils are still pinpoint, there won't be any harm to the patient. So till there are no secretions.
Yeah, so the main thing are these three. They're the ones who are going to kill the patient.
Yes.
Pupils and axillary sweating, all that are gastric bowel sounds are secondary endpoints. The mandatory endpoints are these three. Okay.
Yes, sir.
That's the main thing. And before gastric lavage, you also need to talk about decontamination.
Yes, sir.
What's the most important precaution during decontamination?
Sir, protection of ourselves with personal protection equipments and using gloves, sir, nitrile gloves, or if gloves are not there, you can wear double layer gloves.
So even can we absorb? Where all can it be absorbed?
So from the skin.
Transdermal, it can be absorbed, and it can be absorbed through eyes also, sir. Conjunctival absorption.
Fine. So that you need to mention eyes and skin and protection of the healthcare worker. Fine.
Yes.
You said that a patient has a less history. If the patient is not giving the history, so but how will you handle it? Suppose the patient, many times the patient who has done the suicidal attempts, or patient comes to unconscious to the casualty, and it may make other medical problems, like pinpoint people. It may be a pontine hemorrhage, but that will also present the same way. Patient having fentanyl or opioid toxicity, like in Punjab, we see a lot of patients with that. A patient may come with the bradycardia as well as coma and this pinpoint people. So if you don't have the history, circumstantial evidence, which we call it, so how will you handle the patients? How will you suspect? Like this patient has told that this is OPC poisoning. If the patient is not telling the OPC, then how will you handle it? How will you reach the target? The diagnostics.
I'll approach the toxindromic approach, sir. I'll look for the signs and symptoms which are peculiar for a particular toxin.
So what are those mnemonics people use for toxidrome in this case?
In OP poisoning, so there will be sludge symptoms with BBB, sir. Whereas we'll look for pupil size, heart rate, and blood pressure main, sir.
Is there any bias factor to toxidrome or masking of toxidrome in these patients?
Yes, sir. These patients mostly they consume alcohol also, along with
yes. Alcohol will lead to different, and plus sometimes the patient have a polypharmacy also. Patient may be a substance use disorder, or patient may be a psychiatric patient with the antipsychotics. Is there any antipsychotic which will mask the effect of acetylcholine, this OPC? Where you will not get the classical symptoms?
It's a tricyclic anti-TCI.
Yes. Many patients with antidepressants, they may have tricyclic antidepressants or other anticholinergic drugs, which may be masking the effects.
Yes.
Go ahead.
What are other differential diagnoses of a young person coming with quadriparesis? Suddenly in the morning in our country.
So with hemiparesis.
Quadriparesis.
Water.
Muscle weakness.
Quadriparesis.
Getting up in gone
More
to sleep in
common.
the night,
I'll give you more common in June, July.
slept at night and got up in the morning with quadriparesis.
There can be a snake bite, sir.
Which snake?
Crate bites.
Okay, great. What else?
Botulinum toxin.
Botulinum, seen botulinum at all? Rural country. Rural. Have you seen botulinum? So snake bite is right. What else is likely? Organophosphorus, of course. Guillain-Barré also is possible. No?
Guillain-Barré myasthenia.
GB syndrome is a bit late.
In our country, talk snake bite. You're right. Snake bite should come number one, as like you said, especially in the monsoons. Organophosphorus, and of course, anything is possible, but then of course, spontaneous hemorrhage, all that is possible. But most important is snake bite and organophosphorus and Guillain-Barré in our country. And lots of reasons. You need to know acute onset of acute motor weakness. Fine, go ahead.
Can we trial of? Go ahead, Dr. Hede.
Ask. No, what did you want to ask, Dr.
Can we give a trial of atropine in a suspected, but not giving the history of this thing? Trial of atropine or like snake bite, can we give a ASB in to make the diagnosis? On the basis of toxicological, if there is no circumstantial evidence or the history of OPC, can we give atropine as a trial?
Sir, we can give atropine as a trial.
What is its sensitivity and specificity?
How does it prove anything?
Sir, we see with atropinization, with atropine, we see resolving of symptoms in OP poisoning, but whereas in snake poisoning, we won't be seeing anything. So it can help us in giving a diagnosis, sir.
What will happen?
The atropine reverses the neuromuscular weaknesses.
No, sir.
No, sir.
Only atropine acts on the muscarinic receptors and it
How
will
it
reverse on the muscarinic symptoms.
So it does not, no?
No, it does not. So it can give us a clue, sir, that it is not related with muscarinic receptors.
You want to say something, Dr. Gautam? What do you want?
Yes, atropine trial is acceptable. Even ASP trial is also acceptable. If the patient is having bradycardia, there is no or bronchoria, there is no contraindication to give a trial of atropine. It is a choice we can give it. Yes, any patient with the where the knocking down of the system, autonomic nervous system is there with acetylcholine. Atropine will try to rise the secretion even if it is underdosing, because atropinization, the dose may require very high. Even giving 1 or 2 milligram, if it's not leading to tachycardia, it's safe to repeat again and again so that we can achieve the atropinization in such patients. Even if it's not having any harmful effect, even if you give it a little higher. Even if the patient is not having OPC poisoning, even then it's not going to be harmful.
Yes.
Because unless until it leads to the side effect is only the tachycardia and drying of secretion only. And rarely very high dose, which can be lead to cholinergic symptom because it crosses the blood-brain barrier. That's always a threat. But more important is managing the bradycardia and bronchoria in these patients, so we can give safely atropine. That's recommended.
Can you do any blood tests to diagnose or to strengthen your diagnosis?
Sir, for OP poisoning, we can send pseudocholinesterase level. Low pseudocholinesterase level can give us a hint towards organophosphorus poisoning.
It helps in diagnosis or prognosis or both?
We can.
Sir, pseudocholinesterase is not useful for telling the prognosis.
Why not?
It is non-specific, sir. It can be present in plasma, liver.
It can be present in low.
But it is decreased by organophosphorus poisoning, no?
Sir, even in liver failure or even some genetic related also, it can also be less. So only
different organophosphorus, their sensitivity of pseudocholinesterase is much more than to which is a true cholinesterase, RBC, no?
RBCs.
So many of the organophosphorus compound depress pseudocholinesterase much more than they depress RBC cholinesterase. That's why the prognosis, you can't be prognosticate. It is useful for diagnosis, but you can't use it to prognosticate because you may overestimate the severity because RBC cholinesterase is may not be suppressed as much as the butyryl cholinesterase. That's the main thing. But has it any other value other than diagnosis? So the
we can assess
RBC
the
cholinesterase, of course, correlates with severity also, but it's not easily available. So is there any useful for any other use of pseudocholinesterase other than diagnosis?
we can assess if the patient is improving with the treatment based on regular checking of pseudocholinesterase levels.
You can make out even clinically, no? Why do you need pseudocholinesterase?
So this is very important message to learn. Monitoring, do we use the cholinesterase level to monitor OPC, especially the pseudocholinesterase, subtype cholinesterase?
No,
Do we use for monitoring?
No,
Has
sir.
any role? It doesn't have any role.
Doesn't have it.
Regeneration, how much regeneration is per day?
7% regeneration is said to be acceptable. Like patient is in good trajectory. If the patient is in.
No, some people say that if once all the organophosphorus cleared from the system, then the cholinesterase levels rise. So maybe, I'm not sure. There's one Lancet article which said that rising pseudocholinesterase levels might indicate that now all the organophosphorus compound is out of the system. So this is unless the organophosphorus compound completely out of the system, pseudocholinesterase levels won't rise. There's one reference. I'm not sure it's right or wrong. But otherwise, like you said, there is no role for monitoring.
Monitoring is not, unless until you have the true cholinesterase, monitoring is not done with the and secondly, regeneration doesn't help it. Monitoring the regeneration doesn't help in making the clinical decisions.
Yes.
Another thing is, like you said, liver and this thing. So how will you make the diagnosis if the patient is having CLD or pregnancy or malnutrition? There may be the low levels also. So how will you make the diagnosis then? What is the percentage where you should say, yes, this is cholinesterase level is enough to label it OPC poisoning, not such a false value because
Sir,
of the underlying
we cannot come into diagnosis because the specificity is very low, sir, for pseudocholinesterase.
How much percentage is considered significant? How
Less
much
than
cholinesterase?
Less than 25%, sir. From the
Yes, 25-30%. At least should be less than
25.
30%, 20% is quite significant, but less than anything, 50% still we can take. But yes, 25 to 30% is considered as a significant fall in the normal level that it's a OPC only.
Unlikely to be due to other causes, such as decreased score.
Yes.
Fine, go ahead.
Sir, Pralidoxime was also given at the hospital. 2-gram loading dose was given initially, followed by a maintenance dose of 500 milligram per hour.
So what are your views on how does Pralidoxime work and what are the controversies about Pralidoxime?
There is no robust evidence to suggest Pralidoxime, sir, but it has a grade C, like weak evidence.
How does it work?
Sir, Pralidoxime binds at the serinic side of esteric part of acetylcholinesterase, and it causes the reversible and it reverses the aging process of organophosphorus compound and acetylcholinesterase.
Once it's aged, there is nothing.
It reverses the.
It displaces it from the group binding. No?
Yes, sir.
Aging means irreversible binding, no?
Competitive inhibition, sir. Competitive inhibition.
So once it's bound irreversible, you can't do anything with it. That is aging, no? Irreversible. So it doesn't counter aging. It inhibits.
It prevents the.
Can you explain the aging? What is the aging called? And what is different compounds which have the aging and important? And what are the compounds where you will not use the Pralidoxime at all? There is no role.
So why do you think this is controversy? That's what his point is. Why do you think there's a controversy about Pralidoxime? Why is it not uniformly plus or uniformly negative?
Because of the heterogeneity of the compounds, sir.
That's what he's asking. So can you tell us what are all the heterogeneity which can affect Pralidoxime efficacy?
Dimethyl compounds, they'll go into aging early, sorry, within like less than 3 hours. So
So dimethyl compounds, okay, is one. Dimethyl versus diethyl. Dimethyl aging is rapid, so it will not be effective less than after 3 hours. So that is one. What else can affect?
Sir, even this
Thion
Thion and Oxime group also. Thion will take time to metabolize.
Why it takes time?
Thion is a prodrug, sir. It has to get it has to be activated to get into action.
Activated to what?
Thions will get activated into oxons, sir, by
Activated oxons. So thions. So aging is slower in thions as compared to oxons. So one is oxons. What else is there? Which anything else can affect the aging or the efficacy of Pralidoxime?
Sir, even lipid solubility also can more lipid soluble can also delay the aging, sir.
Delay
Lipid
aging?
soluble.
How does lipid solubility act work, you're saying? Yeah, because it can be stored in the fat stores, it may get released later. So it may
Release later, and
so there may be an effect even later. So basically, that's the whole. What are the major studies you know about Pralidoxime? From India, from elsewhere?
There is a significant study which was done in Baramati, Maharashtra, sir.
Recent. Baramati was not very recent. Okay, Baramati, but before that? Before Baramati, from where?
Vellore, there is one study.
Vellore and which other country?
mainly studies were done in Sri Lanka,
Sri Lankan
sir.
studies.
Sri Lanka, when PAM was not available, they checked, that was a historical controls.
Yes, sir.
So what did they find? Vellore and Sri Lanka, what did they find?
Sir, in Sri Lanka, they were against the use of Pralidoxime.
And
They did
Vellore?
not find any mortality benefit with PAM. In Vellore, they were in support of Pralidoxime.
Vellore? Support of Pralidoxime? No, better read the study properly. Higher mortality with higher worse outcomes with Pralidoxime. Only the Baramati study was for Pralidoxime. Vellore and Sri Lanka were anti-Pralidoxime. That is why the heterogeneity, because like you said, there's heterogeneity because maybe depending on the type of drug the patient has taken, Pralidoxime, and how fast you give the Pralidoxime, it may or may not work. That's why the heterogeneity. No? So ideally, like you said, you have a lipid soluble, you have a diethyl ester, you have a thion, all that maybe Pralidoxime will work, but you have an oxon, you have a dimethyl, not so fat soluble, it may not work. So depending on what, so you have to decide whether it works or not. It's not just one drug may not be for everybody. That's you have to make a decision whether it might be useful or not, because theoretically sometimes it might actually worsen. If you use it for a dimethyl, it may actually make matters worse. So that's why you have to think about how fast the patient has come, what drug he has taken, and the character of the drug, and then decide whether Pralidoxime is likely to work or not. Okay.
Yes.
You want to say
Once you
something,
have-
Dr. Yeah.
Yes, yes. What you have done, the atropinization, suppose you have achieved a very high dose, atropinization going very high dose, maybe 100 milligram or so. Then how will you fix the maintenance dose for these patients?
Sir, we set the maintenance dose at 10 to 30% of the loading dose which we have given, sir. And we continue the infusion, and we keep on checking our atropine targets, and based on that we'll be tapering the atropine infusion.
What would the next course in the ICU? What are the patient where you will have to shift the patient to ICU and manage? Like your patient, this patient was shifted to you because of limited monitoring facility. What is the limited monitoring? What are the monitoring you want for these patients biochemically, or what are the monitors you need to have a lab and these things? What are the things you need actually? Routinely you advise orders, no? So what are your instructions for these patients daily?
Sir, first thing is this patients requires continuous monitoring to look for signs and symptoms. Apart from that, the investigations which we initially go with it is getting one ABG done, sir. Then ABG, one ECG, and checking pulse oximeter, checking the saturation levels along with heart rate. We can also send pseudocholinergic stress level also on at the beginning to confirm our to come to our diagnosis, to help us in diagnosis. Then apart from this, we send all routine blood investigations, sir, which includes CBC, liver function test, and renal function test reports.
Mhm. Is there any help from this prognostication also?
Sir,
If the attendant family is asking, what would the prognosis?
sir,
So what will be your answer?
so for prognostication, we inform the family members about how much quantity if he has consumed. The more the quantity he consumes, the more the poor prognosis it would be. And the time since presentation to the hospital. If there is a delayed presentation, again the mortality worsens, sir. And then RBC acetylcholinesterase, if it is available, it can help us in telling the severity, but it is not
Is there any scale used for this thing also?
Sir?
For quality assessment, is there any scale also people use?
Paradinia's OP scale is
What is its validity and reliability of Paradinia's OPC scale?
Sir, it is very less reliable.
it's not widely used also.
It's not
Mhm.
widely used.
What are the weaknesses? What are the parameters they monitor?
So not sure about this. Recent ISCCM update has told that it is not beneficial.
It's not penny, that is true. That's the reason, because its weaknesses are huge. That's why people have not, because the things it monitor like fasciculations, respiratory rate, and coma and seizure, all these things are not correlating with the mortality. Mortality is more with the what the patient has consumed, what is your services also. Because a lot of things are dependent on how you are handling the patient, this thing, how good you are in atropinization, and then later on what the complication will develop. It depends on the compound rather than actually the scale.
Yes.
You said this is lipophilic. What would the prognosis in obese versus thin patients? Does it make a difference? Body mass index, BMI.
Yes, sir.
No?
In obese patient, there is in obese patient there is a risk of accumulation of the drug in the adipose tissue, and the chances of redistribution is high, sir. So the mortalities will be more in the obese patient,
Mm-hmm.
and there is risk of intermediate syndrome.
Is there a role of NCB also? Nerve conduction studies.
Yes, sir. In to confirm the diagnosis of intermediate syndrome, we can use NCV studies, in which electromyographic studies will show the decrease in amplitudes, compound muscle action potential.
So if you do in first 24 hours, in the acute phase, what will be in a patient with a hidden history, what will be the finding? If patient is in the intermediate syndrome, what will be the finding? If patient gets neuropathy out of this, what will be the finding?
There will be decreased in the CMAPs, sir.
That in
three different stages, no?
Yes, sir.
First 24 hours, the intermediate syndrome and delayed neuropathy.
In first 24 hours, there will be increase in the CMAPs because of the fasciculation tremors, and the intermediate syndrome, the amplitudes will be reduced, sir. And in OP-induced delayed neuropathy, there will be decrease in CMAPs, and there will be decrease in velocities, sir, because of the demyelination and axonopathy.
So, putting the right way is to start with, it's more of like as told, assess like a patient with more going with the more firing leading to a picture. But in the intermediate phase, it shows the fade. And when it's full fade leading, because the mechanism of the neuropathy, what is the mechanism of neuropathy? Because NCB are entirely different when patient goes into neuropathy.
It is, there will be axonal swelling, and there will be degeneration of the nerve cells. Valerian degeneration will be there, sir, basically.
That's why I'm saying, what is the mechanism behind this? What it's a more of acetylcholine or something else?
Neuropathic specific hysteresis mediated axonopathy will be there, sir.
So it's a neuropathy target esterases which are destroyed by the OPC.
Yes,
It's another thing is what the OPC contains the vehicles also. That's also important. It's not only the compound. What is it's along with the vehicles? That's also important. With the solvents.
Yes.
So neuropathy is mostly delayed one. Even sometimes it leads to coma.
Yeah, given this patient atropine, the patient becomes violent. What are the likely causes? Very violent, encephalopathic.
Sir, we
What are
commonly
the
see
differential diagnosis?
atropine psychosis with
Any other differences? Always atropine psychosis or
sir, we can think about alcohol withdrawal
alcohol withdrawal? What is
or
this?
or ICU deliriums.
ICU delirium, day one. No, this patient, ICU delirium is hardly a cause. So alcohol withdrawal, I understand, some drug withdrawal, okay. And even it could even be the effect of the poison itself, no? Organophosphorus also can affect the brain, no?
Yes.
So how do you separate the two? Because one will require more atropine, other requires less atropine.
OP compound induced neurotoxicity usually they will be like delirious with
It will
hallucinations.
be delirious, no? When organophosphorus can make them delirious.
Atropine toxicity, they will be hyperactive, sir. Hyperactive with
That's what I'm saying. They can happen even with basically simple thing. The pupil in one will be pupil tachycardia. Most is pupils. Pulse rate.
What is central anticholinergic syndrome simply?
So the pupils are dilated is more likely to be due to atropine. The pupils are constricted, more likely to be due to organophosphorus, pulse rate, heart rate, all that standard things, no?
yes.
How do you different a cholinergic crisis or a myasthenic crisis? Similar, no? Something similar, no? You know the cholinergic crisis or myasthenic crisis, no?
Yes, sir.
Similar things, no? That's how do you treat? Okay, suppose the patient become violent. He's got a, his heart rate is 50, but he's becoming very agitated. Now what do you do? He's got fever, agitation, but heart rate is still not reached the target level.
Sir, initially we go with physical restraint, then
Physical restraint, but what do you do with the heart rate?
sir, heart rate we continue with atropine, sir.
But he's very more and more violent.
Sir, initially we'll start with atropine, and if required, if very much required, then we'll go with benzodiazepines to calm him down.
Benzodiazepines. But the heart rate, what do you do with the heart rate? His hypotension, the heart rate is 50.
Sir, I'll go with
make matters worse, no?
We'll increase the dose of atropine, sir.
But he's getting violent. He's jumping out of bed, strangling the nurse.
What are
Basically,
the drugs we can change? There is something solution to each
Which
and
are the
every
other
problem.
anticholinergic drugs? The question is, which are the other anticholinergic drugs?
Sir, we can use glycopyrrolate.
Yeah, why glycopyrrolate? Why not atropine?
Trihexyphenidyl we can use, sir.
Trihexyphenidyl. Why? What is the difference between these three drugs? Which is the best CSA penetration?
Trihexyphenidyl.
So somebody is already agitated, are you going to give trihexyphenidyl? Already he's got high CNS effect of atropine. You will not give atropine.
So
You will not give trihexyphenidyl. What you
use
will give
scopolamine also, sir.
which has peripheral
Scopolamine.
action, does not cross the CSF. No? So what will you give?
The drug which doesn't cross blood-brain barrier, is there any drug?
Which anticholinergic drug does not cross the blood-brain?
Glycopyrrolate does not cross.
Glycopyrrolate. So here you want the peripheral actions. You want the cardiovascular effects, but you don't want the CNS effects. So you'd use
Glycopyrrolate.
Where you want CNS effects without too much peripheral, then you would use trihexyphenidyl or scopolamine. You understand?
Yes.
So you want more CNS, you might use predominantly CNS, you would use. So this patient already has high CNS action, but not much of peripheral, you would use glycopyrrolate. No, you can switch to glycopyrrolate.
Yes.
Also, Dr. Peter says that when there's a situation like this, you can use adrenaline. Because he says a sympathetic blockade, you can use adrenaline. When you're worried about heart rate, but CNS is already atropine is already over atropinized in the brain, you could try using adrenaline. Okay. But you certainly will not increase atropine, certainly will not give trihexyphenidyl or scopolamine. Fine.
So when patient presented to our hospital, again we started with an initial assessment with a primary servicer. Here, when a patient presented to us, the airway was patent with no salivation. Breathing was at regular rate at 18 per minute with saturation 98% on room air, and bilateral air entry was clear. There was no wheeze or no crepitations. In circulation, again, heart rate was more than 100 beats per minute. Blood pressure was
That means already patient is stabilized while shifting to your place.
Yes, sir.
Yes, sir.
He was got in a stabilized condition, but only one finding which we found was still pupils were 1 mm, sir. So this was the only sign which we could see.
So do we react to this 1 mm pupil?
No, sir.
No, sir.
No, sir, we did not. Our next plan was to continue ICU monitoring.
What could be other reason why the pupils are still constricted and everything else is okay?
Sir,
There can be local contamination also, sir. On
Exactly. Local, it could be absorbed through the eye. So,
yes,
of
sir.
course, it could also be some other poison in addition, but most likely it is the
local.
local effect of the.
Sir, in systemic examination also no significant findings were observed, but on abdominal palpation, tenderness was elicited. In past history, there were no any comorbidities, no psychiatric illness, and no addiction history was present. Initially, ABG was suggestive of mild metabolic alkalosis with lactates of 1.5 and chloride of 121. ECG showed sinus tachycardia. Chest X-ray showed no specific abnormality was
What
found.
can be the reason for high chloride level in your patient?
So because gastric lavage was done in the other hospital, we believe excess NS was used, which could have resulted in high chloride, and maybe initial fluid resuscitation with NS could have also caused high
Chloride causes acidosis or alkalosis?
Acidosis.
acidosis.
Here, alkalosis, you said, no?
So because patient also presented with diarrhea, GI loss, which
So diarrhea causes acidosis or alkalosis?
sir, more alkalosis, gastric
Diarrhea.
lavage.
Diarrhea
So
causes
your, sir, here your pH is showing the alkalosis side, and chloride is on the higher side, which will lead to hypochloremic metabolic acidosis. How will you go ahead with the calculation in such a mixed disorders? Is there any way to find out what is causing what in ABG? What is expected CO2 in your patient? If the bicarbonate 27,
We'll see by Winter's formula, sir. 1.5 into bicarb plus 8.
Winter's formula used for acidosis or alkalosis?
Metabolic acidosis, sir.
But here the patient is having metabolic alkalosis.
Yes.
Is hydrogenic or alkalosis, or it's a disease induced? It's very important to see the record what has been given to the patient in the previous hospital.
Yes.
The diarrhea.
You said that's normal. IVC is more than 50% collapsible.
What is that called? IVC was due to collapsible and there is alkalosis.
Sir, contraction alkalosis.
Yes. And vice versa. What is the other side of it? Contraction alkalosis and what is the opposite of that?
Acidosis due to
What acidosis is it? Yeah. Dilutional acidosis. No?
Dilutional.
Somebody with diarrhea, the diarrhea fluid is usually bicarbonate. No? They're losing bicarbonate, they become acidotic. When you lose a lot of chloride from doing resuscitation aspiration, losing chloride, you become alkalotic. Okay. You're losing chloride. No? Of course, here the chloride is 121, so that's a little tricky, but otherwise, vomiting causes gastric aspiration, generally causes alkalosis, and diarrhea generally causes acidosis. Now, here we don't know what he has got and all that, we'll have to check. But basically, it's a metabolic alkalosis. No? It's not a...
Maybe they have given a lot of sodium chloride for resuscitation also. Sometimes the chloride loss. What is the loss of sweat in this thing? What is the composition of sweat which we lose from the skin? What is the sodium content of and chloride content of sweat?
We are not sure.
Not sure. See, sweat is a loss, huge loss in OPC poisonings, and it's around 50 milliequivalent sweat. But the volume is so much. That's why the patient becomes hypovolemic and the thing. But it's not the same like plasma. So it will be a different picture once the patient had a lot of fluid losses from the skin. So in OPC poisoning, very, very important to see patient even 50% collapsibility. It's a huge amount which we should, but the lactate is normal. That is a good thing. But patient has been a lot of sodium chloride to compensate for the fluid losses.
Yes.
That may be the reason for hypochloremia. So as far as this management, what else next is?
So, sir, in emergency department, they continued with the atropine infusion and pralidoxime infusion and was shifted to ICU for the further
How
management.
much was the atropine going on per hour?
The 3 milligram per hour.
3 milligram per hour. So how will you taper it off?
Sir, we taper it down by seeing the signs and symptoms. Mainly, what we want is the lungs to be dry. There should not be any secretions. And initially, we target a heart rate of more than 100, sir. And at the same time, we'll be checking the pupils also, sir.
Sometimes, in spite of giving atropine, the lungs don't, you guys still get Krebs. What are the likely cause?
Sir, despite atropine, if Krebs are there, because atropine-induced heart failure or organophosphate-induced heart failure can also start presenting with pulmonary
More
edema.
likely is aspiration first, no? Just aspiration.
Yes.
Because they vomited and all that, no? You're given induced vomiting, induced, whatever. You're doing. First is aspiration, then you think about cardiac, young patient and all that. First is just aspiration. Of course, it will be focal, it won't be everywhere, but.
So, sir, the initial X-ray on day 1 looked clear, sir. No significant abnormalities were noted. And the cholinesterase which was sent was found to be very low at 320. The reference range was more than 4,900 to 11,900, sir.
You really needed that in this patient?
Sir, it was not required because the clinical signs and the history was clearly mentioning that it is a case of organophosphorus poisoning. On day 2, patient had fever and became drowsy with transient hypotension. Wide pulse pressure was noted and warm peripheries were there. And he was requiring NORAD support at 0.1 microgram per kg per minute.
What can be the reason for that? Patient became febrile and drowsy, and along with that hypotension, then you started giving adrenaline, noradrenaline. What was the lactate level at that time? Because
Sir,
your pupil size is already good enough, 2.5.
yes, sir.
So what can be the cause, and what was the prescription at that time?
It can be due to OP-induced hemodynamic collapse because the dimethoate is known to cause circulatory collapse.
After
But
one
your
day,
EF was good function, echo,
Yes.
and the collapsibility is less than 20%. Your 2D echo report is good LV function, collapsibility only less than 20%. That means patient was volume-wise optimal. But still, patient was requiring norepi and transient hypotension, drowsy also. What can be the reason for that?
Sir,
Fever and drowsiness, we can think of OPC induced only or something drug induced, your antidote induced.
Sir, our fever differential diagnosis in this case could have been atropine induced or a new sepsis can also present with fever, sir. And drowsiness can also be due to organophosphorus compounds. And even in fever or sepsis also we can see drowsiness. And there was a hypotension even though fluid status was good. In OP poisoning, autonomic instabilities were noted, sir, in previously also. So this is one possibility.
So do we use antibiotics in these patients, all patients, prophylactically or only empirically or definite therapy?
So there is no indication for prophylactic antibiotics as such, but because patient was drowsy and patient had multiple episodes of vomiting, so we could think that patient would have aspirated. So we could have considered, sir, but it is not definitive.
Okay, go ahead. Next.
On day 3, patient had worsening drowsiness with GCS of E2, V2, and M4, and resulting in worsening of hypoxia. On chest auscultation, bilateral Krebs were present with decreased air entry on left side, and fever was also present. Patient had to be intubated in view of poor GCS and threatened airway. When chest X-ray was done, it was suggestive of left lower zone opacities, probably aspiration or probably pneumonia. Here we have started empirical antibiotics, injections, ceftazidime and sulbactam, thinking that it could be a pneumonia.
pneumonia, pneumonitis, aspiration.
Sir, aspiration pneumonitis.
Was it pneumonia, aspiration pneumonia? What is the difference?
Sir, pneumonia is a bacterial or a viral
Pneumonitis.
Pneumonitis is
inflammation process due to the gastric contents or oral secretion contents. It is the inflammation of the lung. So, sir, empirical antibiotics were started, and ABG showed PF ratios of 187, and lactates were still maintaining. ABG was towards mild metabolic acidosis side only, sir.
Metabolic acidosis. pH.
Alkalosis. Labs, there was a very transient increase in total leukocyte count from 9,000 to
Was
10,200.
it only a metabolic alkalosis? Or? With the bicount 26, what do you expect the PCO2 to be? Normally, when the bicount is going up, what happens to PCO2?
PCO2 should come down.
Come down. Because metabolic alkalosis.
PCO2 should come.
Should increase, sir.
PCO2 should increase, sir. Sorry.
So ideally, this is both, no? Respiratory and
Metabolic alkalosis with respiratory alkalosis.
both are there. No?
Yes, sir.
No, these
So
mistakes.
patient,
Yes,
still
someone-
patient on ventilator, no?
No, sir.
Hmm?
Sorry, sir.
Patient is still on ventilator.
Yes, sir. Patient was intubated on day 3. Here we can see endotracheal tubes are in the X-ray, along with central line was placed.
So respiratory
Mhm.
alkalosis was basically hydrogenic, not hydrogenic. The settings were.
So when you will start thinking of intermediate syndrome in such patient, and when you will go with the tracheostomy or not tracheostomy, so how will you decide on these issues?
Sir, intermediate syndrome usually arises after 24 hours to 96 hours duration, and it can be seen after 1 week also. Mostly it can be seen in after 1 week also, sir. So
When you will suspect it, and how will you diagnose? How will you manage it?
In intermediate syndrome, there will be proximal muscle weakness, sir. When patient is not able to lift his neck, or when the diaphragmatic excursion is weak, and when there is central axial muscle weakness will be there, sir.
and
Any cranial nerve involvement or no cranial? Which cranial nerves are affected?
Cranial nerves are involved, sir. There can be a chance of bulbar weakness.
Which other cranial nerves?
When you will decide that patient should go with early tracheostomy or late tracheostomy in these patients? Or they don't need tracheostomy?
sir, intermediate syndrome may require a tracheostomy. Regarding the decision of early tracheostomy and late tracheostomy, we have to see how the signs and symptoms are progressing, sir. On basis of that, we have
How you assess the respiration part, the lung mechanics on ventilator in such patients who are getting weaned off from the ventilator in OPC poisoning?
we can see
Because
diaphragmatic.
they have a muscle weakness, they have issues with the chest also. So how will you assess the weaning on such patients? So
We can see diaphragmatic excursion in these cases. When if diaphragmatic excursion is low, it will hint us towards early tracheostomy, sir.
diaphragmatic excursion only based or something more than that also you can perceive.
And diaphragmatic thickness fraction can also be seen.
If you don't have ultrasound, then
On percussion also we can see, sir.
percussion. Percussion of what? Percussion of chest or abdomen, but you want to percuss
Sir,
to assess the lung mechanics.
we can see RSBI P 0.1. On basis of that also we can decide.
Or you interpret P 0.1.
Sir?
You said you will assess the occlusion pressures 0.100 milliseconds this thing in lung mechanics. So how do you interpret this?
Sir, if it is less than 1.5, there is reduced neuronal drive. If it is more than 4, patient is having more drive towards it. Normally, it should be
So it's
between
very poor indicator. What about the negative inspirative force and But how do you see clinically whether the patient's lung mechanics are acceptable or not in ICU?
So by use of seeing accessory muscles during respiration
Mm-hmm.
and
So what is the criteria for if you have to wean off the patient from ventilator?
sir, if
All
I have to,
patients who have whether it's LGBS or OPC poisoning or any other condition, when you are weaning the patient off the ventilator,
first,
what is the clinical criteria and
so first the cause of requirement of ventilator. What was the cause? If that is cleared or not, we should see, sir, if that has been eliminated or not. The
good.
cause. Then we have to see if the patient is hemodynamically stable. PF ratios are maintaining more than 150 or more than 200.
Mhm.
We
Yes,
have to,
this patient is completing the criteria.
But he was he was drowsy and his GCS was low, sir.
Yes, so patient should have a conscious level and enough inspiratory and expiratory force, cuff or flex.
yes.
Next.
So, sir, on day 4, again, the atropination targets were maintained. There were no secretions, no crypts. There was no diarrhea. Pupils were 3 mm and sluggishly reactive to light. PF ratios were improved compared to the previous day. Encephalopathy still persisted, sir, on day 4. On day 5, there were no secretions. There were no cholinergic symptoms. There was no fever also. Pupils were at 3.5 mm, sluggishly reactive to light. Encephalopathy persisted, and we had to continue mechanical ventilation due to
What is the
persistent.
reason for persistent encephalopathy?
Sir,
Differential.
Sir, in this case, we were thinking due to prolonged atropine leading to encephalopathy. And
Okay, one.
other differential
Anything else?
could be organophosphorus toxin induced encephalopathy or sepsis induced encephalopathy.
Good. 3. OPC itself can lead to, that's good.
Yes.
Anticholinergics, yes.
Yes.
Agree with sepsis. Anything else? Which can happen in the emergency day 1 only.
Initial hypoxic event
Yes.
can also cause encephalopathy.
And maybe patient having something else, alcohol and other drug polypharmacy, that may be another reason for this.
Yes, sir.
Non-convulsive seizures always, encephalopathy always talk about NCS also.
NCS, yes.
So on day 6, encephalopathy improved, but patient developed neck flexor weakness and was not able to hold his neck. And when diaphragmatic excursion was checked, it was 0.7 centimeters, which is less. There were no cholinergic symptoms, no secretions, no crypts, no diarrhea, and pupils were at bilateral 3 mm and sluggishly reactive to light.
On day 7, the atropine infusion being tapered and stopped because the cholinergic symptoms were weaned off and the encephalopathy was improving. So we thought of the possibility of tracheostomy, but on day 8, the patient was tolerating the spontaneous breathing trials. We have given a trial of CPAP, and then we have planned for extubation with explaining the risk of reintubation. And the cholinergic signs, there were no evidence of cholinergic signs. So on day 9, the patient was extubated and he was maintaining on the room air. And this is the ET cultures, which is suggestive of Pseudomonas. As we have started on cephalosporin sulbactam, so it was sensitive, but so we have continued with the same cephalosporin sulbactam, sir.
And patient also showed clinical improvement, so we did not escalate any antibiotic further.
So, your patient has been fine. Is there any role of Plex, CRT, extracorporeal limb therapy, and FFP?
Sir, there are no
Because
strong.
pollen phase is absent. If you just supply with the plasma, this will be substituted immediately. Is there any role of this? I've told 3-4 therapies. Is there any role of these?
There was a study done in Turkey in 2004, sir, which was suggestive of use of fresh frozen plasma because it contains butyryl cholinesterase, which may increase the half-life of butyryl cholinesterase. So in that study, there was the role of FFP, which was beneficial. But there is no robust evidence which suggests the use of hemodialysis or RRT, sir.
What about the extracorporeal therapies?
So
Day one.
there are no strong evidences in favor of this, sir. It is a few here and there studies are there which showed benefit, but there are no strong evidence.
So why there is not a strong evidence coming up? Any reasons for selection bias or this thing?
Because sir, in OP poisoning classification, there is so much variability, few being more.
Yes, there are so many compounds. Each and every compound is not handled with this thing. There are specific compounds only which can be handled with the extracorporeal, and it has its complications also.
Yes.
How do you delayed encephalopathy by, what is managing delayed encephalopathy with organophosphorus?
Yes, sir. There is a chronic OP-induced neuropsychiatric disorders also, sir.
Neuropsychiatric, they can even be encephalopathic, they can even mimic brain death.
Yes, sir.
How do you separate brain death from?
In brain death, the pupils will be dilated, sir.
How do you treat this? Okay, that's fine. The pupils are pinpoint. So which drug do you use to treat this? Same thing. Now, which drug has good CSA penetration?
We continue with
No, better than atropine. Which anticholinergic drug has CSA penetration?
scopolamine.
Scopolamine or triaxiphenyl. You only mentioned. So
Yes, sir.
you can use atropine, but otherwise you can use a drug with better CSA without less peripheral actin. So triaxiphenyl or scopolamine is the best.
Yes, sir.
So they can come with extraperipheral manifestations. They can come with encephalopathy. They can come with severe coma.
Yes, sir. We can
And
use
you can also have delayed neuropathy. So what is even delayed peripheral neuropathy and intermediate syndrome?
intermediate syndrome, which occurs in the early part of the OP
Actually,
component.
what's the difference clinically on examination?
Intermediate syndrome will have proximal muscle weakness, sir, whereas delayed neuropathy will have distal muscle weakness with sensory involvement also.
Proximal and distal, yeah, fine. And the intermediate
last
oculomotor
question.
nerves are also affected. Other than the pharyngeal, your oculomotor nerves are affected. I mean, the muscles of oculomotor, third, fourth, sixth nerves.
Yes.
So last question from my side. Like this patient was a LSD history. If patient doesn't give any history, you come to know only third, fourth day that the patient has attempted a suicide by taking the OPC, and patient was become conscious, gives the history that he has taken. You took the psychiatric consultation. Is there any role of a police information at that time? That's our duty or not? If you are not done police information day one, but patient gets this, you come to know later on that this is probably a suicidal attempt or homicidal, maybe by someone in the family or other members, friends. Where do you stand for this OPC poisonings? Should we give police information or not?
Yes, sir. We have to give police information whenever we get to know that there is some medical legal. We have to inform.
Good. That's our duty also.
Yes,
As per
yes.
the law.
I think we have covered everything.
Yes, from my side, both are very good and fast.
Thank you.
Yes, sir. I think that was really an extensive discussion where you have covered everything, sir, almost everything possible. And I think, as you said, I think they did really well, sir. So I am just checking for any audience questions, sir. If any audience question is there, just I will see. Not much questions in the chat, sir. I think the only question from my side was probably the role of triple combination therapy, because the newer evidences are coming, atropine plus PLAM with hemoperfusion, sir.
Yes, to the examiners.
No, sir. To the students, sir.
Yes, please go ahead.
Sir, because hemoperfusion is a costly affair, and most of the OP poisonings are seen in farmers and with the financial problems, sir. I think it will be very difficult.
And when we have an antidote, we will go with the antidote, sir.
Yeah, I think that is a very practical answer. But scientifically, what we are looking at is there any benefit?
So, may I answer it now? Partially, I'll answer because the trial sometimes driven by the industry also. Specific compounds, there are a couple of compounds which can be handled very nicely with like dichlorophos and dimethadone. That can be cleared by charcoal hemoperfusion. It's not that costly. It's a filter are specific for these, and they cost around 15,000-20,000 the filter only with the simple dialysis machine. Not difficult. But putting a vascular access and all these things, which can be most of the patient otherwise in OPC poisoning, doesn't really give them mortality benefit. Most times, if you handle supportive care as such, most of the patient will get through easily with the atropine and the glycopyrrolate. Most of the times, that's the, I think, so far charcoal hemoperfusion, if we know the product and that's a filterable and with the charcoal hemoperfusion, only then, otherwise I don't think it should be a conditional, not be for all patients.
Yes, sir, absolutely, sir, because it is not universally applicable. The other
Absolutely.
point for
And there are more
discussion
than
is
130-40 compounds, more than that, herbicides and these things. So not possible to use for each and every patient, not the recommendation, I would say.
yes. The other newer question which is coming up is, role of agents like magnesium and ketamine, which have been tried again in organophosphorus poisoning, sir.
Yes, magnesium has its role as such because sometimes these patients throw arrhythmias also, and cardiac arrhythmias are known, and there is a loss of this thing also. Magnesium definitely sometimes we supplement in our patients also. I don't know what about you and Dr. Hegde has an approach. Magnesium we do use in sometimes in these patients.
Yes, sir. Although there is no much mortality benefit, but patients probably with cardiac involvement, where a prolongation of QT or arrhythmias, probably these are the
Yes.
subset of patients where we probably can
We do
selectively
use
use magnesium, sir.
Even sometimes they get AF also. Cardiac arrhythmia is well known for these
Yes,
patients.
sir. Yes, sir.
Because of sensitization, because of atropine, sometimes these patients throw arrhythmias.
Yes, sir.
Even ARDS is known with the OPC poisoning. They sometimes we look at an infection, but it comes to be ARDS also. And people have documented ARDS in OPC poisoning.
There are two questions in the chat, sir. How common is acute pancreatitis in organophosphorus poisoning? And the second question is regarding recommended duration of PAM infusion. I think students can take this question if they want to answer.
Sir, as per WHO, the recommended duration of Pralidoxime is 48 hours, sir. But again, there are no robust evidences about the prolongation of Pralidoxime. And sir, what was the other question?
Acute pancreatitis.
Incidence?
Acute pancreatitis in organophosphorus poisoning.
So we are not sure about it.
Incidents I don't know, but we do find sometimes.
I think probably very rare, but not a usual complication, I believe.
It doesn't require any great treatment, doesn't change anything.
Yes.
And duration, I think, also depends on the kind of drug they've taken. I think we can't have one protocol. I think, like Dr. Gautam, there's so many drugs. Each one will probably have to individualize. If it's has got a fat soluble drug or it's a late aging, you probably can continue PAM a little later. But beyond 48 hours, probably not. If it's a dimethyl compound, probably even 48 hours may not be enough, not be required. So I don't think I have one answer for everybody. It depends on the kind of the drug they've taken, when he has come, how soon he has come. So many things to decide before deciding what to do.
Yes, sir. Because a lot of dilemmas, the evidence itself is questionable. Again, the severity of toxicity, presentation, whether,
I think we have to individualize and see if they're getting better quickly. Obviously, you will stop faster. If they haven't, you can't. And depending on
What is the warfare status? Anyone want to answer it? Warfare status of OPC, the international law.
Sir, it is,
So,
it is strictly
you know?
not allowed. It is strictly not allowed to produce or to store any warfare substances.
Yes.
Obviously, but despite this, we are seeing in recent wars, it's being used.
The peop- Yes, I think one of the country, I won't name that because it's very controversial, but one of the scientists leaked out the information that they are making the compounds because individual OPC compound is not allowed, but they have created the components which once thrown together, they can make OPC very quick and very fast aging process. So that's why some of the armies, they have kept the persons who go for the rescue in those cases, the atropine and the pralidoxime enzyme as a combination drug in the pens. So once they go with the rescue, they inject themselves with that and they go with the rescue. That's the protocol there.
Okay, sir.
Thank you, sir. Thank you, Ashish sir and Gautam sir for joining and making this such a wonderful discussion. And I think most of the students who have attended this masterclass would have definitely benefited from the discussion from the exam point of view. Thank you. Thank you for supporting us, sir. We'll close this session, sir.
Thank you.
Thank you.
Thank you, Rahul and Naresh. Yeah.
Thank you, sir.
Thank you.
Bye.
Thank you, sir.
Bye bye.
Bye, sir.